looks like we're open. I see the recording button on. Welcome to all of you to our very special session today. Many of you may have heard that last week, a number of academics across the country had organized to host special events both yesterday and today around the topic of Black Lives Matters. And we, over the weekend, looked at that and said, we should do something in public health. This is a very critical issue for us, and in particular, the issues around mortality. I think many of us had our eyes opened after Hurricane Maria to the fact that many times deaths are not counted. Deaths are not counted. People die, and if their lives don't count, their deaths don't count. And that has a profound effect on then what we're doing in public health, what we're doing as a society to invest to protect those lives. And so we were able to put together what I think is going to be a very important and dynamic program and conversation that will be moderated by our very own Dr. Amanda Castell. Amanda is a professor of epidemiology in our School of Public Health. She is a pediatrician. She is a leader and has been a leader for a number of years in the prevention of HIV/AIDS, morbidity and mortality, particularly focusing on the really unmet needs for control of HIV/AIDS in the Black population, especially here in the District of Columbia and our region. But we're also going to have a number of other very dynamic presentations that Dr. Castell will introduce. And so I'm going to turn to Dr. Castell now, welcome her, also convey my great appreciation to her for being such a great member of our faculty, somebody who not only has made an enormous contribution to the control and prevention of HIV/AIDS, but in the last few months has thrown herself really full bore into the issue of COVID-19 and making our city, making our campus safe. So welcome to you, Dr. Castell.
Us together for this teach-in and for the opportunity to discuss, in our community, how systemic racism and injustice in the U.S. disproportionately impacts Black lives. As Martin Luther King Jr. said, our lives begin to end the day we become silent about the things that matter. And so this is really an extremely important discussion because Black lives do matter, and we as a community cannot remain silent. As an epidemiologist, I tend to focus on data and numbers, and so I wanted to just give you all some statistics around this topic of Black deaths matter that will hopefully provide some context for our discussion and presentations. So let me start with some questions for you all. Did you know that when it comes to police violence, that Black people are 3 times more likely than white people to be killed during police contact? In 2019 alone, there were 235 Black people who were fatally shot by police. Police killings of unarmed Black Americans are responsible not only for many deaths, but for an estimated 15 million additional days of poor mental health among Black populations. And what's even more disheartening, particularly as a pediatrician, is that these types of disparities start at birth. There was a recent study that showed that Black babies, newborn Black babies, are 3 times more likely to die after birth when cared for by a white doctor compared to a Black doctor. And 1 out of every 3 Black boys today can expect to be sentenced to prison, compared to 1 in 6 Latino boys and 1 out of 17 white boys. And so while these statistics aren't new to many of us, I think that the recent rash of violence and police brutality and killings among Black people and communities of color has really, highlighted and really brought to to bear a reminder of where we are these days. And particularly as well, the disproportionate impact of COVID on communities of color has also reminded us about these longstanding historical injustices and disparities in care. Many people talk about the Tuskegee syphilis experiment, but I think that it's important to understand that some of these disparities have been around for centuries. So with respect to COVID-19, right now, the pandemic is really wreaking havoc on Black communities and communities of color. I'll give you a few data points. 1 in 1,125 Black Americans has died, for an age-adjusted mortality rate that is 3.6 times higher than that of whites. Black people, we know, are more likely to suffer from the comorbidities that can put someone at higher risk for severe course of illness, such as cardiovascular disease, hypertension, obesity. And we also know that the social and societal context in which many Black people live are known risk factors for COVID deaths. These include living in dense and impoverished areas, living in crowded multi-generational housing that doesn't allow for proper social distancing, working in essential jobs. All of these are issues that make Black people more vulnerable to COVID. And multiple studies have demonstrated these strong associations between these geographic, structural, and cultural factors and the higher death rates among Black people. One study found that if COVID deaths had been equal across racial and ethnic groups, almost 20,000 Black lives would have been saved, and almost 8,400 deaths among Latinos would have been averted. And even here in DC, in the nation's capital, we've seen this disparity. We see that Blacks account for 51% of COVID cases, and yet 75% of deaths from coronavirus. So as Dean Goldman mentioned, I am a HIV researcher. And for me, all of these disparities are all too common when we look at the impact of infectious diseases on communities of color. We know that Blacks account for 13% of the US population, yet 23% of COVID deaths, 25% of people living with chronic hepatitis C, and 42% of new HIV diagnoses. And so despite the availability of life-saving treatments, such as highly active antiretroviral therapy or combination ART for people living with HIV, when you look at death rates among people living with HIV, they're still highest among Blacks. In fact, in 1996, when highly active antiretroviral therapy became available, the proportion of deaths among white individuals living with HIV declined. However, the proportion of deaths among Black individuals living with HIV increased from 29% to 52%. Again, highlighting this disparity in access and care and treatment. And even now, if you look at deaths among people living with HIV, 52% are among individuals who identify as Black or African Americans. HIV continues to be among the 10 leading causes of death among persons aged 25 to 44 who are living with among people who are 25 to 44 years of age, with homicide and unintentional injury being the top 2 causes. So I've given you a lot of data, a lot of statistics, and a lot of information about these health disparities. And I think what we'll talk about today is why. Why are we seeing these health disparities? And there's so many reasons: delayed access to care and treatment, testing deserts, which we've already seen with COVID, and we've certainly seen with HIV, economic instability, food instability, housing instability, lack of health insurance, racial segregation, disproportionately high rates of underlying health conditions, cultural mistrust, intergenerational trauma, low health literacy, healthcare provider bias, all of these things. The list just goes on and on and on. And so I hope that today we can learn more about the science and the public health impact of these disparities from our esteemed panelists, but also have time to sit and talk and discuss and think about solutions and actions that can help us make meaningful change. And so with that, I'm going to turn it over to our panelists. I'm going to start with Dr. Roger Mitchell. Let's see if he's been able to join. Okay, well, maybe we'll go then to Dr. Carlos Santo Burgoa, who's a professor in the Department of Global Health here at GW in the Milken Institute School of Public Health. And he will be speaking with us about addressing differentials in mortality analysis to drive inclusion, the case of Puerto Rico and the NCR. So Dr. Santos-Burgoa, I'm going to turn it over to you.
Lynn, you want to talk?
I am going to be timing, so I'll let you know when you have a minute to wrap up, Carlos. So do you want to get started?
Okay, I will. Okay, thank you. And Amanda, thank you very much for that introduction. You just made me feel the, you know, the upsetting of this situation. But let's move on.
Carlos, one moment. I'm sorry. I'm going to interrupt. I see Dr. Mitchell on, and I know his time is extremely limited. Dr. Mitchell, Dr. Santos-Burgoa had only just started, and if you don't mind, I'll shift things over to you because I know that you need to kind of speak and run, and I want to honor the fact that you have a lot of responsibilities. If that's okay with you, Carlos, we'll shift over to Dr. Mitchell. Amanda,
good.
Introduce him first.
I apologize.
That's okay. Hi.
So let me introduce Dr. Roger Mitchell. He's the interim deputy mayor for public safety and justice and chief medical examiner. And he works in the office of the chief medical examiner. And he's going to talk to us about structural racism and need to engage a public health approach. So Dr. Mitchell.
Well, thank you so much for inviting me here. As you all know, I'm a GW alumnus, and so anytime I get an opportunity to talk to you all, I revel in that opportunity. I want to start off with a story. I was a second-year medical student, first-year medical student, and had just left the FBI, where I was a forensic scientist, a biologist for the FBI, and had just started medical school in New Jersey. And I remember coming home in between classes to get something to eat. And I like to watch the evening news when I eat dinner. And breaking news was a 23-year-old African man who was shot by law enforcement. He had been shot 42 times, hit 19. He had entrance wounds in the soles of his feet. And come to find out, he was reaching for a wallet in the vestibule of his home when he was shot and killed. His name was Amadou Diallo. The story of Amadou Diallo as a first-year medical student put me in a position where I knew that I wanted to study police use of force as a public health issue. As a medical student and a future forensic pathologist, I felt that it was important for me to lend my voice as a physician to this conversation of law enforcement force. And so first year, the end of first year through into second year, when all of the trials were going on, I would study my studies in my apartment and in my car on the way to protest in the middle of Manhattan. And so since then, as a second-year medical student, I wrote the first paper on police brutality as a health issue for the Student National Medical Association, and been studying law enforcement force and lecturing on law enforcement force since. In 2017, we put out a paper at the National Association of Medical Examiners looking at how these deaths should be handled by medical examiners and coroners throughout the country. Making sure that there's a uniformity of practice surrounding forensic medicine for law enforcement involved cases, whether shootings, whether asphyxia cases like we see in George Floyd. And so now as the chief medical examiner, that is functionally how we handle all cases. In addition to that, I've been calling for a box on the US standard death certificate. You as public health providers know how important mortality data is to understanding how the disease or injury burden to a community. And right now, there's no real way for us to objectively measure how many people are dying in custody. And not just those that may be dying in the streets in encounter with law enforcement, but also the natural deaths that occur while individuals are incarcerated. Individuals that are in their early 50s are dying from complications of their diabetes mellitus, obesity, and hypertensive and atherosclerotic cardiovascular disease. So this construct of deaths in custody occur over a continuum from a pre-arrest phase all the way through an in-custody phase, all the way through incarceration to include judicial executions. And there's all of the manners occur across that continuum, whether it be accidental overdoses from someone who was able to get drugs while incarcerated, to natural disease as described before, or homicides that we saw with George Floyd and other police shootings that we have recently, even in our city. And that continuum needs to be measured from a public health standpoint, not just from a law enforcement standpoint. And so if this is a public health issue, then we need to be able to measure it by looking at the U.S. standard death certificate. And who better to certify and report and to accurately monitor these deaths than physicians or public health providers, not necessarily law enforcement. And so here in the District of Columbia, we have a checkbox on our U.S. standard death certificate here. We have a checkbox that my physicians in the Office of the Chief Medical Examiner check. And this is something that we developed since I've been here and since our mayor has been in office, so that we're objectively looking at these deaths in custody. And so what I want to do is I tell you all of that from the time in which I witnessed via the television a 22-year-old, 23-year-old man that looked just like me getting shot for no reason 19 times, piercing his body, to now sitting as your interim deputy mayor in the city and the chief medical examiner of the city, that advocacy in the public health space is critically important. That our voice as public health providers and physicians are extremely important. And that we cannot abdicate our responsibility in speaking truth to power, but we can also not advocate our responsibility in thinking that our work ends just with a singular patient or a singular community. Our job is to generate information and research and practitioners and expertise that lead to long life in all communities, particularly communities that are disenfranchised and communities that have lack of access. So when we're talking about structural racism, we're talking about the social determinants of health. We're talking about where we live, where we work, where we love, where we have our being. We're talking about our education, economics, housing, healthcare, and criminal justice. So those social determinants have just as much impact on our health outcomes as does our intrinsic biology. There are particular genes that make my skin brown. Those skin genes, the TYR is probably the best known gene that that acts as a tyrosinase and converts and allows for melanin to be active and more active in my skin than someone of a lighter hue. But I'll tell you right now that tyrosinase gene, that TYR gene, does not create an environment for me to be killed by law enforcement at a higher rate than anybody else. That TYR gene does not make me more susceptible to hypertension and diabetes and prostate cancer and breast cancer. That TYR gene is not responsible for that. So what is? It's structural and institutional racism. And so it's important to understand that, because in medical school, at least when I was coming in, Blackness was a risk factor. And probably some of you are in classes where they say Black people are at risk of. Black people are more at risk of. But the reality of it is that my Blackness doesn't make me at risk. It's the structural and institutional racism that makes me at risk. It is the institutions that have been set up to decrease and minimize equity. And let me tell you, these structures are we're not talking about individual people, because you can be an anti-racist and be participating in a structurally racist environment. But as us as anti-racists, we have to try to deconstruct wherever we see it. We can't be silent about it. And this is the time. And I'll end with this. This is the time. We are a chosen generation to be able to dismantle what has been built over since the 1400s. We are a chosen generation to be able to deconstruct racism in a way that allows us to give access to those that need access and a voice to the voiceless. So those of you right now that are protesting in this environment, that are not engaging in your scholastic activities so that you can show your solidarity with Black lives, this is for you. And for those of you that are voyeurs and trying to understand it, let me explain something. That it's not enough to say racism is wrong, you have to be anti-racist. And to be anti-racist is not to be anti-white. To be anti-racist is not to be necessarily pro-Black. To be anti-racist is to understand that there is structural inequities that have been built into every system of jobs, education, economics, housing, environmental, and criminal justice. And if we're public health providers, public health researchers, physicians, nurses, practitioners, then we must deconstruct the social determinant. Violence and the violence that we see in law enforcement are symptoms of a system. They're symptoms. And as long as we're just treating symptoms and not the disease, then all we will get is patchwork. So I encourage you all, I appreciate you dealing with the fact that I couldn't jump on when I was supposed to. I appreciate your willingness to have me be involved in this conversation. And so I want to thank you so much for the opportunity, and really, really good luck to all of you. God bless.
Thank you, Dr. Mitchell, for those very passionate words. Your energy, your commitment to the struggle of Black people and people of color clearly comes out in your comments, and we thank you for that.
And there's work to be done. So, let's not just make it words. Let's not just make it words and fancy titles. Let's not just be, we're excited because we were in this room. Let's really go to work. And going to work means sacrifice. You might not get home on time. If you're like me, I have to explain to my children why I'm not home, and my wife, and I'm coming, and I promise. But it's a sacrifice. So everybody has to sacrifice. Nobody gets to stand on the sideline in 2020. Later for that. Everybody works. So you don't get to commentate on what politicians are doing and what other people doing if you're not doing anything. And I'm telling you, it's not enough just to serve your patients. You got to do more than that, because people are at risk. There's so much at stake right now. So register to vote. Go find someone to put them in your car and get them to a voting poll. So thank you so much for having me. I'm sorry I got to jump off, but God bless y'all. If you need me, you know how to get me. We're looking for people to want to do work in community. We're looking for people that want to give up their time, talent, and treasure. So some of you multimillionaires that are on the phone that want to fund violence interruption work, we have an opportunity for you too. If you don't have the time, we'll take your treasure. All right, so God bless you guys.
Thank you very, very much. Okay, so with those words to get us going, I'm going to also now reintroduce Dr. Carlos Santos Bergoa. He's a professor in the Department of Global Health here at the Milken Institute School of Public Health, and he's going to share some of the data and research that he's been doing addressing differentials in mortality analysis to drive inclusion, the case of Puerto Rico and the NCR.
Well, after Amanda's and Roger's speech, I think it's hard to follow both of you. But let me try to share my screen and continue. Can you see it? Okay. So let me move on addressing the differentials in mortality analysis. And there are two keywords in this title. Mortality is different, and there are differentials in mortality. But the important thing is not just to quantify the deaths, but how we make them drive inclusion. And that is, I think that is part of my frustration and part of my goals in the case of Puerto Rico and now in the National Capital Region. So what I will do is I will briefly tell you a little bit about what we did in Puerto Rico, the question that was posed to us, how we looked for it, and what were the results. And then I will move into the pandemic and tell you about a little bit about the total excess mortality analysis that have been done recently, and the project that we are building now for the National Capital Region. We are just starting on this. Puerto Rico. For those of you who don't know, Puerto Rico is an island in the Caribbean that has been a territory of the United States since 1898. It's a territory, not a state. And that has brought a special relationship between Puerto Rico and the continental United States. So this is a little bit of a story of not a single group, but a whole island population that is being discriminated over the years. Here is the recent data on Puerto Rico. On the top, you have the population of Puerto Rico that was in 2010, the estimated for 2019. It's a reduction of 14%. In 10 years, Puerto Rico has lost at least 14% of their population, if the census is right. And a lot of this is related to the economic situation in the island and how the young population has been migrating out of the island into the continent as they are U.S. citizens. Once they move into the continent, the whole situation changes. So talk about social determinants, talk about structural determinants. Well, that's what's happening immediately. This is you see the racial composition. Most of them qualify themselves as Hispanic or Latinos. Really, if you talk to the people in Puerto Rico, regardless of their actual race, people say, well, we're Hispanic, we're Latinos. And in fact, there is a problem in the classification of race in the island when surveys are performed there. Look at the poverty rates. The poverty are huge. It's one of the largest poverty rate in the United States, considered by median household or per capita income. What happened in September of 27? Well, they had a huge storm, a huge hurricane that, as you can see in the bottom image, it covered the whole island. Not a single corner of the island was spared. It went through the island, and it was category 5, at least 175 miles per hour. But these winds in the mountains, in areas where they have tunnels, this speeds of wind increased at least 80%. So the winds were, yes, there was a lot of water, but the winds were destroying everything in its path. When Dr. Lynn Goldman and me attended a meeting with the governor of Puerto Rico in December 21st of 2017, the whole island, the whole society was in crisis because the government had accounted for only 64 deaths. And nobody believed that after all this had happened, there were only 64 cases and there were many estimates going around. So the question by the governor was, tell me how many deaths we actually have. So being counted. So they gave us the freedom to look at this. So we looked at the historic data from since 2010 up to August of 2017. And using that historic data, we made a forecast of what should have been the mortality from September of 2017 to February 2018, and the differential between the expected versus the observed was what we determined as the excess mortality. So here you have the excess mortality for September, October, September, December, and September, February, and this was the official data that was we communicated to the government, and that is now the current officially accepted data from 64 to 2,975. Just imagine the size of undercounting that they had gone through. But that was not the only thing that we found. We found that the difference was important for men. Men were much higher hit by, and older men. The older the men were, the higher their risk was over time. But what was amazing is to see this trend with the lowest socioeconomic group. So as time passed, they were not only hit hard, but they were dying more and more and more and more over time. We were talking with the governor in December. As we were starting the study, people kept on dying and dying more and more in the worst off population. And nobody was doing anything different to take care of this group. And that is what ended up being one of our strongest messages. You have, once you measure, once you identify something, you have to act on that. And if you are going to build a surveillance system that measures and counts deaths, well, make sure that identifies the differentials and acts on them. And that recommendation we posed to the government, and so far is not yet there in place. So that's part of the frustration that we do have. This is the certificate in Puerto Rico. Dr. Roger Michel, he talked about the certificate. Yes, this is it. This is a huge public health instrument. We have it. And in the case of Puerto Rico, they do have a good classification of race, if they are Hispanic or not, and also other socioeconomic statistics that are really not being used. And we have a lot of valuable information in the death certificate that we are not using. It's interesting, the National Center for Health Statistics, in the case of Puerto Rico, they mentioned that in case of validity of race definition, you have to think that everybody is Hispanic. No difference in race. So I would say this is being ignored over time. What's happening in terms of this, in terms of COVID? This is the change in mortality in the 2020 in comparison to the 5 previous years. So you see that the increase in mortality in Blacks, Hispanics, and Asians is much higher than in whites over time. So this is something that you say, well, come on, why is this happening? It's quite outstanding what you just see from the rates. So this is the situation in the DC, Maryland, and Virginia area. This is the trends of COVID cases, not COVID deaths, but COVID cases. But look at the cumulative number of COVID deaths just in DC. Distribution by race of the deaths, their percentage distribution. What is the percentage distribution of the population, and what's the ratio between these two? 1.62, the ratio. It's just clear. You don't need any sophisticated statistical modeling. It's right there. It's shouting. This thing is shouting. This is the total excess mortality that's happening. Has been accounted for up to May 30th of when we defined the proposal for this study, and at least 500 more excess deaths, of which 400 are COVID and 100 more are non-COVID cases. So why are they dying? There are people who are dying that is not COVID related. So why we're having this excess? And most likely this excess is in this population.
Carlos, 1 minute. 1 minute. You need to finish.
I am about to finish. Dr. Mitchell was talking about the structural social determinants. Here you have that from a recent report by the Pan American Health Organization. Here you have the social determinants of health, ethnicity, and race included in this, and how they eventually drive the distribution of health and well-being. So it is true what Dr. Wallace says. We have to pay attention to the overall social determinants that are driving this structural thing. So in the case of this study supported by the university, we aim to focus. We're going to focus in the National Capital Region, and we want to improve mortality surveillance, to integrate the current electronic mortality data into the databases, to exploit and gather the information on poverty, race, and other socio-demographic information, compare it with historic trends, and use this information of excess mortality to target interventions in real time. Hopefully this time we can make it happen. Thank you very much. That will be my presentation.
Thank you very much, Dr. Santos Burgoa, for really highlighting not only the impact of Hurricane Maria in Puerto Rico and that excess mortality, but also what we're seeing in the DC region and the importance of actually using the data, to change policies and to develop interventions. So thank you very much for that work. Next, we have Dr. Wendy Ellis. So Dr. Ellis is an assistant professor in the Department of Global Health here at GW in the Milken Institute School of Public Health. And she's also the director for the Center for Community Resilience. Dr. Ellis is going to speak with us this morning about the pair of ACEs and white supremacy.
Well, good morning, everyone. I'm going to try to get through this really quickly because I want to make sure that we have time for questions. So in our work at the Center for Community Resilience, we really do put equity at the center of everything that we do. So when we talk about resilience, we're not just talking about an individual's ability to bounce back when, Dr. Mitchell and certainly Carlos has shared with us that our starting points are very different dependent upon our race and our location, our race and place-based starts. And so those things, there's an intentionality that drives those outcomes. And so understanding that when we talk about resilience, we are looking at how do we create these equitable access to these supports and buffers that help individuals not only bounce back from, say, a hurricane or from police brutality and community violence, but actually help them move forward and thrive. And that is why we put at the center of our work this necessary need to connect those systems back to the community characteristics, which you've heard Carlos, which we've heard Dr. Mitchell speak to as social determinants, but really think critically about, are they truly deterministic by individual actions and behaviors, but are they deterministic because the systems and our policies have been engineered for those outcomes? And so in our work, we use the adverse childhood experiences, this framing of understanding the connection between what's happening to individuals, but also zoom out to understand those adverse community environments. So when we think about the 10 traditional ACEs of maternal depression, emotional and sexual abuse, substance abuse, domestic violence, physical and emotional neglect, divorce, mental illness, incarceration, parental incarceration, homelessness, these are outcomes that certainly can be measured at the individual level that have a negative impact not only during childhood, but can also be associated with negative outcomes with regard to obesity, diabetes, heart disease, early onset of mental illness, as well as substance abuse and other issues. So yes, those things can be measured at the individual level, but when we zoom out, we also have to consider the adverse community environment. So hence the pair of ACEs, these things that are in the soil of our community that actually, if not produce these outcomes, certainly exacerbate the experience at the individual level. So we hear oftentimes in public health, this discussion around lack of opportunity and economic mobility and social capital, poor housing and quality and affordability. And we point to those as an individual's outcome, as opposed to thinking about these through the lens of these are actually systems outcomes. So these are systems that are producing these outcomes, not necessarily individuals who are partaking in this. And so when we think about it from that perspective, then we begin to understand a system's role in producing these outcomes and also producing better outcomes for our communities. And so this is the framing that we use in our community resilience work that certainly has allowed us and provides this opportunity to speak directly to understanding the role of structural racism as a root cause. That these outcomes, particularly in COVID-19, has given us an opportunity to reframe the pair of ACEs to understand now what we see as a community-wide experience, not just what's happening to individuals, but what's happening at the community level with levels of food insecurity, this lack of access to primary care and screening, this lack of access to paid leave and unemployment, how individuals are classified as essential employees, and disproportionately that's happening to individuals at the lower end of the economic spectrum. So when we begin to connect these outcomes of disproportionate deaths, when we see the word gap spreading with our children because of this lack of access to high-speed internet, and understanding that, you know, learning from home doesn't mean the same thing for all of our children. So again, it's the same elements that are in our soil that are driving, that are being exacerbated by COVID-19, and puts us in public health at the center of the major social justice cause of our time. And so how did we get here to be talking about from public health and thinking about just outcomes to really looking at the soil, these determinants that were built from a policy standpoint? Well, that requires an understanding of more than 400 years of US policy. And this is absolutely necessary, because if we don't understand the policies that are driving the outcomes and we only focus on changing behaviors and health promotion, we will miss the opportunity for real long-lasting change. And we're talking about systemic change. So the work that we do at the Center of Community Resilience is putting policy and understanding policy and how it's been used as an instrument of white supremacy to ensure white supremacy as an outcome. So let's take a quick walk through history, and I'll make it quick because I want to save time for questions. But oftentimes we speak of slavery in this country as being our original sin. I want to disabuse you of that fact, because actually our original sin started with the Native Americans back in the 1400s. And yes, slavery was built on that blueprint, but understand that the systemic oppression and subjugation of individuals began with the Native Americans in this country, with 3 pivotal acts that set in place intergenerational trauma for Native Americans. So with the scalp act in the colonial era, you had bounties for eradication of Native Americans in the colonies. Many of these lands that were cleared were then later used to set up for plantations. So the Marshall Trilogy was this series of Supreme Court rulings that established federal supremacy over indigenous affairs, limiting rights of Native Americans to profit from their own land and resources, and made tribal nations wards of the US. The 1830 Indian Removal Act and Preemption Act paved the way for settlers to claim tribal lands in the West, moving more than 100,000 tribal members west of the Mississippi River. Nearly 4,000 died in the 5,000-mile trek across 9 states. That is the seeds of intergenerational trauma that is passed on. So when we look at what has happened with African Americans, we have to understand that the same systems and policies, what they learned from oppression of Native Americans, was applied to Africans, but not for eradication and genocide. It was certainly put in place for subjugation, oppression, and control. So, and that was said and codified in our Constitution that granted voting rights to only white male landowners, establishing white male supremacy at the outset, while also upholding slavery. The Great Compromise granted unequal representation in Congress to Southern states that allowed them to count slaves as 3/5 human, codifying inferiority under the Constitution. Now, many will point to the series of amendments, the 13th, 14th, and 15th Amendments, as, well, we took care of all of that. But did we? When you look and examine the 13th Amendment, the abolishment of slavery, there's an asterisk. As my grandfather taught me and a lawyer, he said, always read the fine print. And so in that fine print of the 13th Amendment, while slavery was abolished, there's an exception, except as punishment for a crime, which paved the way for mass incarceration that continues even into the 21st century. And so how do we know this? It's because suddenly after emancipation, we had the adoption of Black codes that criminalized unemployment, that criminalized poverty, that allowed for the widespread uptake of recently freed Africans back to the Angola plantation in Louisiana, which went from overnight being a plantation to that state's first penitentiary, and still operating today in plain sight. The 14th and 15th Amendments guaranteed equal protections under the law and voting rights for all men, regardless of race or color, but they were quickly undermined by the establishment of Jim Crow laws, Black codes, and poll taxes. Many states then established sundown towns, further restricting residents to whites only, which laid the foundation for segregationist limits on home ownership that were amplified by New Deal housing initiatives in which the federal government limited mortgage protections to homes being purchased in whites-only neighborhoods. This led to the practice of redlining by banks, producing place and race-based outcomes in wealth, health, and well-being that can still be measured today. So let's move forward on that timeline to examine the 1954 Supreme Court ruling of Brown versus Board of Education. Despite this ruling that held that America's public schools were inherently separate and unequal, more than 60 years later, our nation's public school systems are more segregated than ever. This is due to the dubious practice of drawing district lines in a fashion that often reinforced racial and economic segregation, coupled with the practice of funding public schools on local property taxes, despite the history of redlining that today still influence place and race-based patterns of poverty. Though redlining was banned more than 50 years ago, 73% of formerly redlined neighborhoods remain areas with the highest concentration of poverty in most US cities, providing a smaller tax base for neighborhood schools. And this pattern of lower educational attainment and under-resourced schools follow these same patterns of economic disparity in household wealth and reduced investment in public schools. This is inequity by design. So as this timeline illustrates, public policy over the course of our nation's history has worked effectively in ensuring that Indigenous, African American, and Brown children and their families carry an undue burden of poverty and oppression in the United States, have the least amount of wealth, the highest rate of chronic disease, and shorter life expectancy than their white peers. These outcomes are not by accident. It is white supremacy by design. And my closing words here are, when we talk about white supremacy, it is indeed a public health crisis. And we are not talking about individuals walking down the streets in robes and carrying tiki torches. I'm talking about structures that actually empower those beliefs that white people should dominate all other races. That is structural racism. That is what that timeline illustrates. These systems and policies that were designed to empower a white supremacist belief and produces white supremacy as an outcome. That is the work that is in front of us. As public health advocates, it's not enough to speak to just disparity. It's to understand the policies that are driving the outcomes that we see. Our systems are not broken. They are working efficiently to produce these outcomes. We as leaders in public health, it is our job to understand these policies and work with community in dismantling this system and building more equitable outcomes for all. So thank you.
Wonderful words to end on. Thank you, Dr. Ellis, for reminding me of the centuries of inequities and structures and policies that have been put in place that really are the root of our society, and how we need to move forward to deconstruct and dismantle those policies and structures. So thank you. For the remaining few minutes, I'm going to turn it over to Dean Goldman to moderate a Q&A session with our panelists.
Thank you so much. And we just have very little time actually that remains in the session, and we are going to have to close at 11. But I just want to say, I think this is the beginning of many explorations of these issues that we will be involved with in the Milken Institute School of Public Health, as well as the university as a whole. Looking at what has been placed in the chat box, I think that it might be useful, because we do just have a brief period of time to, first turn to each of our panelists, and I'm going to include Dr. Castell in this, to say, okay, from the standpoint of us as, what are we? We are academic public health people. Each one of you, what is right now the most important thing that we could be doing, or even that you are currently doing to help to, whether it's to illuminate, address, intervene in this crisis, and perhaps starting with Dr. Castell and recognizing the history of our institution, which, like all institutions, reflects structural racism. That's in the chat box. I think that's definitely true. All of our institutions do. We didn't talk about the university much, but comments about the schools certainly pertain to universities, all the schools. But starting with you, Amanda, hi.
Yeah, I'll just be brief. Two really important things, I think. One is that a lot of times we in public health spend a lot of time describing these disparities, and I really do feel like Dr. Santos Bergoa was saying that it's really important for us to then take the next step, use those data for action to make sure that we are being able to intervene and to make a difference in people's lives, and recognizing that these are century-old problems, but that every little bit makes a difference. My other thought is just that right now, my concern is that we lose momentum, and that oftentimes, COVID and other things come to light, and we are full force, full speed ahead, and then we get distracted by other things. And so I just urge everyone to keep these issues at the front of their agendas. You know, it's the little things that matter, whether it's getting out and voting or, you know, finding research dollars to understand some of these disparities. We all play a part.
Dr. Santos, Carlos?
Yeah, this has been a splendid session. I have learned a lot, and it's really a very strong one. I would say it's a sequence of messages. First, not everything is smooth, and not everything is equal. So the first step, yes, is to identify the inequalities, the differences. So that's the first step. The second step is to put it into our system. The third step is to move it into policy. What Wendy said, they have to transform policy. And we cannot rest happy just, oh, what a nice paper I did publishing the inequalities and a p-value that is really significant. No, that is not enough. We have to make sure that they get inserted, translated into policies. I think the message that Wendy said, how we build policies that drive specific outcomes, we have to think about it seriously, and that's very important. Thank you.
Wendy Ellis, Dr.
Yes.
Ellis.
Yes, so anyone who knows our center knows we're all about action. I see many of the messages about what steps to take. And so that is where we focus specifically to begin with on housing, public education, law enforcement, and criminal justice. All of our social determinant literature shows us that these are the areas that have the most deterministic outcomes on our health and well-being. And so we work directly with those systems, work with our communities across the country to really examine critically both local, state, as well as federal policy, as well as creating opportunities where we can have levers of change. We will start this work today, but it will continue well beyond us. And that's why, particularly in academia, we have an obligation to not only illuminate and highlight these policies, but also train the leaders of the future who will continue this work. As that timeline shows, it is 400 years of dismantling that we have to do. This will not happen in my lifetime, but I sure as heck am here to guarantee that what we get started will continue to go beyond 2020. So get started, look at the policies, and think critically about the outcomes. Look beyond the person, look way upstream to the policies and the systems that are driving this, and create the solutions, because we can dismantle this, and we will.
So in closing, thank you so much, all of you, for your wonderful input. Just for the audience, none of these people had more than a day or two to prepare this, but they've been working on these issues their entire lives. And it is the commitment of our faculty and the commitment of our colleagues in public health that inspires me to come here every day to do what I do. But also, I want to thank Natasha Kanzim. She's noted that this recording will be made available. She and others, who work with us in public health, they stepped in to get this done very quickly. And I can't be more grateful for the space that they are working to create for us so that we can have these conversations and share this information with our community. I think that is a part of creating change, but we do need, as they all said, we need to get ourselves to the table. We need to get ourselves to the policy table. We can't be bystanders. We have to be participants. And if I can, close with that as a message, as well as my gratitude to my wonderful colleagues who are able to put this together, and to all of you who came on board with us to participate today. Thank you so much. It really inspires me to see so many people who are interested and have come together so quickly to be able to share this with us. Thank you so much. Have a great week, all, and remember, Black Lives Matter. Bye.